if I could just have everybody enter your name and your contact information in the chat, it kind of helps us to all get to know each other. As you heard, we are recording this echo session. We do this for educational purposes and quality improvement purposes on our end. So just by participating in this session, you're consenting to be recorded. If you do not wish to be recorded, we just ask you to go ahead and disconnect from the session. So ECHO is an interactive community. We have presenters, stakeholders, community members all here together where we communicate and support each other during a session. So one of the best parts is we can be engaged and we can ask questions after the didactic. We can provide feedback for the cases and really just learn from each other. I'd like to just give a little plug on our case narratives and our discussions. These are a wonderful way that we can get support on difficult topics or difficult cases. So if you haven't had the opportunity to do a case narrative yet, we would invite you to do so. Just a little bit information about when you're sharing information about another person, we would just ask that you could please de-identify the person that you are talking about. Avoid any of their real first, middle, or last names or initials. Please don't identify family members, friends, coworkers, etc. And if you have a question on de-identifying, go ahead and reach out to a hub member. Our hub members are the people whose names have an asterisk in front of them, and they're there to help with any questions. So just a little bit about an echo session. Our key components, we will have a didactic speaker first. Following them, we'll have the case presentation and a chance for everyone to give recommendations to the case presenter. This is also a great opportunity to do some professional networking and get to know each other in our communities. So I just like to invite you to take the opportunity to go ahead and rename yourself. I think we all have had lots of practice doing that, being on Zoom for a while. So go ahead and click on that and rename yourself if you don't mind saying your name, your state, and the association that you are affiliated with. Also, if you have a question during the didactic period presentation, you can go ahead and raise your hand. That's a good feature, and we will help you out with that. If you would like to pre-register for the echo sessions, it allows you a chance to receive the materials for each session in advance. And you can do that by our emailing projectscope@usu.edu. We are able to earn professional development credits by participating in any of these sessions that we have. To receive these credits, we need you to please fill out the evaluation form that is sent to you after you attend each session. Throughout the presentation, Janelle will just be dropping in the survey link in the chat box. So if you'll just watch for that and go ahead and fill that out so we can do that. Also, if you pre-register for the echo sessions, it can expedite your receipt of your credit. Just a little bit about Canvas. Canvas is the platform that we use to put our information out. This can help you prepare for these sessions and have a chance to go back and review them again afterwards. To do that, you will need to be registered on Canvas. If you would like to, just go ahead and send us an email again at projectscope@usu.edu, and we will help you get set up with that. Just another plug for our case studies. This is a really great opportunity to share information about real life situations that you might encounter in your profession, and a great chance to just hear from your colleagues about recommendations that they might have. These have been really fascinating, interesting, and at the end of your, after you present your case, then we get this feedback back to you, so you're able to get a lot of great suggestions and recommendations on things that you can take back and use in your everyday professions. So we would love to hear from you. If you would like to do a case presentation, go ahead and just email us again. And these do not have to match what our didactic is. It could be on anything related to this. Echo. All right, just a quick plug on our social media. You can follow us on Facebook, Instagram, and LinkedIn for more ways to connect. Okay. Well, we are very excited today to hear from our presenters. We have Kalli Markle and Jamie Mecham, both from USU. And today they are going to be talking to us about auditory processing and trauma. So we're really looking forward to this presentation, and we will turn the time over to Kalli and Jamie. Thank you so much for being with us today.
Thanks so much for having us. So I am a clinical audiologist here at Utah State. And so for this presentation, they had a few learning objectives for us to go over, which is just to talk about the different organizations that have created guidelines for auditory processing disorder, and talk a little bit about the controversy for diagnosing auditory processing disorder based on gold standards. And then going into what we do here at Utah State, which includes a complex auditory brainstem response in the greater context of diagnosing APD. So in the United States, I think majority of audiologists and speech language pathologists rely on the American Speech Language and Hearing Association, or ASHA. And then we also have the American Academy of Audiology, which we call AAA, not for your car, but for your hearing. And then we also have leaned pretty heavily on the British Society of Audiology when it comes to APD guidelines. So when we've looked at ASHA's guidelines, they were previously published back in 2005. Now there's no data associated because it is available on their website. And they give suggested diagnostic criteria and interpretations of these test results. And so what they're saying is that if there are performance deficits in auditory processing in one or both ears, those scores have to be at least 2 standard deviations from below the mean, or to have 2 or more tests, or within a battery of 2 or more tests. So you need to do at least 2 tests and at least 2 standard deviations below the mean in order to note that they might have auditory processing. If we see poor performance observed only in 1 test, we may diagnose or we may withhold the diagnosis. If it falls 3 standard deviations below the mean, then we might want to accompany other functional difficulties with that diagnosis if we choose not to withhold it. And it's important to administer and compare results across several tests to measure the similar auditory processes to look at patterns in what the abilities are for these kiddos. Any inconsistencies across the tests may signal that there's some other comorbidity or confound, where it may be attention deficit or a cognitive deficit. And so we may be getting some influence with those. So that's according to ASHA. And what they really look at is these 3 areas of auditory processing. And so we're looking at auditory discrimination, which is being able to distinguish signals across different mediums. Is it different in loudness? Is it different in pitch? Is it different in duration? And that's what auditory discrimination is looking at. And then temporal processing, which has to do with the timing aspects of sound and hearing. So how do we integrate timing cues and have resolution with the timing to be able to understand what signals are coming in? And then binaural processing, or using both ears together. So using both ears together helps us localize where sounds are coming from in the horizontal plane, and then lateralization is in the vertical plane. And so understanding how someone can process information using both ears when maybe the signal is not clear, it's degraded, or there's competing information, how do those two ears work together to process information? They also include a tidbit about electrophysiologic measures, which are looking at the neural processes in the auditory system. And so it's a higher level objective measure. And these can include things like the auditory brainstem response, middle latency response, late evoked response. P300 is another late evoked response, mismatch negativity, a lot of acronyms in audiology land. We call it alphabet soup. But what's helpful about these electrophysiologic measures is that we can then test kids who maybe cannot participate behaviorally. So they may be very young, they may not have English as their first language, if we suspect any other disorders, and just whenever anything's inconclusive, we can use this as a tool. Very similarly, the American Academy of Audiology published guidelines in 2010. Really what they recommend is a cross-check principle. So using a test battery that looks across different patterns in the auditory processing and making sure that we use a comprehensive test battery so that we're looking at all parts and mechanisms and different levels of the auditory system. They say that we want our test battery to have proven validity and efficiency for this population, which we'll talk a little bit about in the controversy side of things. And they include that more does not mean better. So doing every single test under the sun doesn't mean that we're going to have a better outcome. It's really trying to tailor to that child and their needs and decide which testing would be most helpful for them. And again, they add a caveat. These guidelines are not exhaustive. They're not intended to serve as the sole source of guidance. They are just there to support you, and you still have to use your clinical judgment. So at that point in time, 14 years ago, this was kind of the best option that they were recommending, which is to look at these areas. Very similarly to what Asha describes, we're looking at specific auditory processes in the temporal, timing side of things, dichotic listening, which again is using both ears together, but now distinguishing one versus the other. So if you're talking in my right ear, can I attend to my right ear, but ignore what's happening in my left ear? So kind of the opposite of binaural, but how we use both ears together. And then also testing monaural low redundancy speech. So if we take away clear characteristics of speech, can that person still understand what's happening? Again, localization and lateralization for binaural testing and that similar discrimination test. They do also include that there are other measures that are not used to diagnose APD, but may be helpful in that process. And they ask the reader to look at the ASHA document. So they're kind of working together to include what really audiologists can do to test for auditory processing, which then impacts our speech language pathology colleagues who are providing that intervention, as well as possibly other providers in the care for that child. So again, they do mention in their guidelines the potential use of a electrophysiologic measure, which is the ABR. And that can be a really helpful test that has been known about and published, but isn't utilized very often. And it's something that I'll talk about in our new protocol that we've been using. But what they also include is that there's no widely accepted criteria as to how we should be using these tests. So at this time of publication, they recognized that not everybody has access to electrophysiologic testing because it's most commonly used in research and is not always clinically available. So again, whenever we have an issue with behavioral testing, can we use those electrophysiologic measures? When we started to revamp our protocol, we leaned heavily on the British Society of Audiology, where they have provided us a newer, well-validated questionnaire for APD patients. And it's been standardized for UK children age 6 to 11. And it has its own acronym, the ECLIPSE. And so the Eclipse is really nice because it includes 5 scales to look at auditory processing, environmental sensitivity, language, memory and attention, and pragmatic skills. So it really breaks apart where the difficulties in processing may be from the caregiver's perspective. And as you can see, this was published in 2018. So we're looking at a little bit newer information. In their guidelines, they again say there continues to be no universally accepted diagnostic criteria or test battery, just to use your best clinical judgment and use a number of tests to look at different areas to understand how that child is performing. But they do include speech perception tests, one of which is the LISTEN-S, listening and spatialized noise. And so that's a test that was developed some time ago that we were able to acquire and add to our test battery. And then we also have a speech and noise test called the BKB-SIN, which has been really helpful in our practice because we are age normed down to 5 years old. So we can test younger and younger and provide that early intervention rather than having them wait until a certain age because the testing might be tricky. They also include the piece about ADR and how that might be helpful in understanding how auditory perception is impaired for kids who present with auditory processing difficulties. And so then we can move on to our second objective, which is just looking at that controversy. So there are a lot of practical problems with the arbitrary criteria in our professional guidelines. These were highlighted in 2013 by Wilson and Arnott, who looked at different scenarios for diagnosing APD based on the criteria provided, where the diagnostic rates range from 7.3% to 96%. And so that's a really huge range as far as how do we diagnose what's going on in these children if we don't have a common approach for testing and evaluating how they're doing. When we look at the Sydenheim-Gutentag criteria for a gold standard, and in looking at how do we even define what APD is, we have a need to define it more clearly. And I feel up to this point in time, APD has been a very much umbrella term. It's been used across providers in the community where, well, it must be an auditory processing issue. But there are so many things that fall under that. And so we do not at this point have an unambiguous definition of what APD means. And so as a clinical entity, APD doesn't have well-defined criteria on how do we assess and look at these kids. We're also not looking at a homogeneous patient group. So when we look at the kids who present with auditory difficulties, they don't all look the same and they don't all have the same deficits. And so using the term APD for these kids, again, feels like an umbrella and kind of this last resort. Something must be going on and it must be auditory processing. Let's refer for that. Which is good, and we need to know their deficits, but it just makes it really hard for us to really pinpoint what's going on. It also must facilitate diagnosis and intervention, and Jamie's going to talk really well about what we've been able to do. This will turn around, it'll get positive, I promise. But it's just been really hard to facilitate how do we diagnose these kids when it's audiology diagnosing, and then it's SLP intervening. And how do we connect with each other to really provide the services that these children need? And we're also not representing a perceived limitation, at least based on what we know about APD right now. And so when we think about sensitivity and specificity of testing, we should have a higher validity of what these tests are showing. And unfortunately, across the board, based on what people are diagnosing, the ranges is huge. And so if in some cases your screening test shows that everybody has APD, that's not going to be valid or reliable in really pinpointing who needs what support. So to go on to our third learning objective in talking about the complex ABR. This is an electrophysiologic measure. So we put little sticky electrodes on the kiddo's head and ears, and we play sounds through insert earphones. And the auditory system is so fascinating and amazing that the stimulus that you can see in gray is presented, and the auditory brainstem will follow that response. So this complex ABR is also known as a frequency following response. The brain is able to imitate what the sound is that's coming in, and to a really high degree, a high level. And so with that testing, we're using an objective measure. The kiddo just sits there like this cute picture. Sometimes I'll just have them rest and close their eyes on their recliner. And we're looking at what their auditory function is, but it doesn't require them to raise their hand or repeat words or repeat sentences. And it can also look at progress following intervention. We can test children of any age. I've done this complex ABR as young as 1.5 years or 2 years old. So it gives us more opportunity to look at where kids are performing when they may not even be communicating fully yet. But we do have norms on developmental changes with age as far as the timing goes. So a younger person will have a slower response time compared to the stimulus, compared to an older person who has more listening experience. So when we decided to look at our protocol, we thought that we would base it off of Nina Kraus and her research, where we need to understand how are sounds getting in. And so we have plenty of tests in audiology and that are well validated to look at how are they hearing peripherally? How is the sound getting in? And then we need to understand, can they make meaning from those sounds? Do those sounds come together as phonemes and then as words and then as sentences? And how do we understand what's happening from those sounds? So we have different tests to look at speech understanding, and we can also look at questionnaires like the Eclipse from the British Society of Audiology. And then the last thing is how accurately these sounds are represented in the auditory system. Again, using that complex ABR, which is also known as a speech ABR or an FFR. Too many acronyms. But what's nice about this strategy is it doesn't restrict the evaluation to a specific test battery or a patient population. It means that I can look at children who may have other comorbidities and other diagnoses, and we can still support them in their auditory processing. So what that looks like for us is doing an audiogram, where we're understanding how a child listens to your basic beeps in the sound booth. I heard it. And then we also look at their middle ear system by measuring tympanometry and acoustic reflex thresholds. Then we also look at their inner ear system using otoacoustic emissions. And we're doing all of this to rule out hearing loss, as well as any other auditory dysfunction. A very common differential diagnosis in these cases is auditory neuropathy spectrum disorder, which is the neural dysynchrony in the system. And so they look very, very similar. So we need to make sure we're ruling that out before we get into processing. And then, as you can see, we added that Eclipse questionnaire from the BSA. And then we were able to acquire the Listen S test, which has the child listen to sentences in different conditions. And so the graph shows you here the different conditions where there's a main talker and then a background talker, all coming from the front. And those voices are the same voices. So the same person who's talking is the same person who's saying background noise. And then we can separate those out. So it's the main talker with the distracting noise off to the sides of the ears. So there's a spatial difference in how they're hearing. And then the other two conditions change the distractor voices. So it's a change in frequency, a change in that temporal piece, and how they use both ears together to understand that there's a difference between two voices. And those come from the front and then also from the sides. And so this gives us information on spatial processing, memory deficits. It also lets me know if we suspect any attention deficits just by the order of testing, and if maybe they're fatiguing or getting tired throughout the test, which I think is helpful because it can be a lot of testing sometimes. Then we also use our BKB SIN. These are just the names of the creators who made it. Sentences and noise. And what happens is the talker is at a certain level and the noise starts really quiet, and every sentence the noise gets progressively louder. And the noise is a multi-talker babble. So it's also known as a cocktail party effect, where, you know, if you're in a busy party and you're trying to talk to someone, there's all this chitter chatter in the back. To try and make it as realistic as possible. And so this test is reported in a signal to noise ratio, so we know at what level they get 50% correct. And then we have norms listed here for that loss. If they have a signal to noise ratio loss, then we can say they probably are having some difficulties when they're in difficult listening environments. And so what is appreciated about this test is that it has normative data, it's a valid test, it has a lot of rich semantic context, but it doesn't tax your bottom-up processing. So it's not getting that same interference as some other tests. And then our colleagues here at Utah State, Majimaraj and Nagaraj, were able to show that this is not impacted by memory, attention, or language ability. So again, we're trying to just hone in on that listening piece. And then my favorite caveat about this test is looking at the interpretation for children, that it should be done on a case-by-case basis. We know that we have standard numbers and scoring, but looking case by case helps us know that even if this child has a normal or near normal signal to noise ratio loss, that might be different enough from where they were before that this feels like they're having a much harder time in school or at home, and that we should really look at it individually. And then again, we added our complex ADR. And what's really nice is we're getting a lot more research that's more recent in looking at how language difficulties, cognitive deficits, APD deficits, hearing deficits are all impacting listening, right? It's this huge overlap. We're not just looking at hearing and isolating hearing and listening alone. This is that same complex ABR wave recording, and Kraus and her team were able to test kids who were typically developing, had auditory processing and speech specific language impairment. And so what you can see is that they all look very similar. And it's, well, they look similar, but the two latter groups are delayed. It's a little bit tricky to see with the coloring, but we're seeing overlaps between the APD and the SLI. And so it's important to know also how we're able to use the complex ABR in our test battery. So from 2019 to 2023, we saw 26 kids in the clinic for auditory processing evaluations, mostly male, at an average of 11 years, but a 9-year mean. And 12% of the kids did not complete all behavioral tests for whatever reason. They got bored, they didn't want to participate anymore. And then 2 children exclusively said, I am not letting you put those stickers on my head, and I will not sit for that complex ABR. So most of the kids, we had a full battery. It was 88% that we got a full battery. And so with those clinical findings, using some of the APD tests that have been used for decades, and following the ASHA and AAA guidelines, we would have a 57% diagnosis rate, which for me falls right between that range that I already talked about, where it went from 7 to 90 something. So I'm kind of in the middle there if I use that diagnostic criteria. There were also some areas where testing was really inconsistent. They would do worse at what would be considered an easier test. And it's hard to know if that's fatigue throughout testing, or if that's maybe a confounding thing we need to focus on. But when we look at that complex ABR, the objective measures showed a delayed timing, a delayed latency in their response for 96% of the children. So that was really interesting that these two numbers are very different, at least in our clinical population. Similarly, the ECLIPSE questionnaire also identified 96% of the children as having huge concerns from their caregivers who filled out the questionnaire. So these two tests are indicating that almost all of these kids have an auditory processing deficit, whereas our behavioral tests and using that battery approach from AAA and ASHA is giving us somewhere kind of in the middle. And so that sounds really good and it is really helpful, but then I wonder if the complex ABR might be too sensitive, because we also see delays in kids who have reading difficulties, dyslexia, specific language impairment, like I mentioned. There's a lot of overlap with those comorbidities. And so it's hard to know how much this is impacted by that, but it's also been a really helpful tool for us. Even with the possible limitation, all of Krause's research is consistent with recommending music training to improve that timing or latency with how sounds are getting in and represented in the neural network. It also seems to be a viable treatment to recommend music training for people who have comorbidities, and there's maybe other things going on. And then, at least for me, the complex ABR can be configured on most clinically available software, and it only takes 15 minutes to obtain the test results. And I can look at kids who are much younger than the originally recommended age range for APD, which is typically 7. So again, the insights are to recommend music training, possibly some remote microphone technology in the school systems, and of course, our lovely colleagues, SLP and neuropsych, to see how they're doing in other areas and understanding their deficits. I didn't update the slide, but as of the last time I had talked about this, we hadn't had any families retest the ABR after intervention. I now have one. Sweet kiddo signed up for music training, ended up not just learning the violin, which, oh my gosh, so hard, but amazing, but also picked up the cello, doing so much better in school, reports that she's so much happier, more engaged, and her ABR got better. It got faster. So her latencies are more appropriate with her age at this point after that intervention. So other intervention options are using remote microphone technology. So that's a teacher wearing a microphone and having speakers in the classroom. There are ear level listening devices as well. But what it does is the two things of reducing distance from the speaker, where when you're further away from the speaker, the sound is a lot quieter. And then also in a very busy classroom or work environment, just wherever there's noise, it reduces that the signal to noise ratio. So we're basically eliminating background noise by using remote mic technology. And this can be available in schools, but would have to be written into an IEP or a 504. And then music training. So this has been really interesting to see, where comparing musicians and non-musicians, having kiddos have music training consistently, and even adults. So their study also included adults, but young adults, school-age children, we see a significant improvement in their complex ABR when they have that music training, and it's consistent. And I think they've continued on with a longitudinal study, so they're looking at how does this impact things over time. But we do have a lot of research on musicians in general and how great musicians are with their auditory discrimination, their temporal processing, their binaural processing, because they have that training. So future directions, we have a lot of great researchers here on campus that we work really closely with, looking at how children are interpreting sound, how they're processing information, what we can do to support them, really using our patient-centered care, family-centered care, and child-centered care to make sure that we're listening to what they say are the concerns, and then truly collaborating with our colleagues to understand all areas of what that child needs and not trying to focus too far into our own bubble. Right now, we're testing with the tools that we have available, but hopeful that we can implement new tools to make the diagnostic process easier on both clinicians and on the families that need them. I'm pretty sure Jamie has this in her section too, so I'll skip over it, but our colleagues made this wonderful graphic to just visualize how everything impacts listening. And another newer published article that breaks it up even into more detail, just thinking about auditory processing, speech processing, and language processing, and how all of these things are truly interwoven so that we can give these kids what they need. So that was my section, and I lost track of where the chat is, so I don't know if any questions popped up. Nope. Okay. Are there any questions before I hand it off to Jamie?
I have a question really quick, Kelly. My name is Natalie Allen. I'm a nurse practitioner and I work with kids in rural areas. And it seems very common these days for the autism reports to come back recommending auditory processing testing. Can you give me a hint or a clue? Because I think it's just coming across on almost all the reports. Are there certain characteristics that should alert me to send them for testing, or should I indeed be sending all of these children for testing?
That is such a great question, Natalie. Thanks for sharing. I see it a lot too, actually. And that's where a lot of my referrals do come from, is these psych evals that recommend a lot. And I'm sure since you've been seeing them, for anyone who doesn't know, we're talking like 80-page reports of a full neurodevelopmental evaluation, and then sometimes a laundry list of diagnoses or recommendations, right? They're saying you might have autism, but you also have PTSD, and then you also have anxiety and depression. And so we recommend you do these 20 things, right? It kind of feels like a lot sometimes. So I do take them with a grain of salt. I am more than happy to see any child that you all feel like may need this testing. But I think what helps me a little bit in knowing how much I can support these kids is if they have many diagnoses, I think a lot of those are going to be kind of the foundation of what their needs are. Like those are going to be important to address pretty early on, right? If they have anxiety and depression, I think connecting with a psychiatrist and a psychologist or counseling, right? That's going to be really important for that child. Not necessarily let's schedule APD right away, right? So I think we can kind of prioritize just depending on each case. And I think any patient or person that you're seeing, child that you're seeing, where it's just a bigger concern. You hear that, well, I can hear you, but I don't understand you. I get lost at school. Like, it's not because I'm not focused, like I'm trying to focus on my teacher, but I just can't process what they're saying or understand what they're saying. Or, more commonly, the kids that I see who aren't referred for psych, they're saying things like, I got in trouble at school because I didn't hear the teacher give the instruction. And so it's a little bit more focused to the listening piece, compared to the kids where it feels like, yeah, we're telling everybody to go through all the hoops, that I don't know that our hoops should come first, at least. Does that help?
Yeah, it does a lot. And then real quickly, I know that we are doing, and I'm not, actually, it's not you guys. Never mind. Sorry. Nope. I'm done with my questions. Thank you.
Okay, thanks.
Kelly, it looks like we have another question from Nishta. She has her hand raised. Nishta, if you want to come mute and go ahead and ask your question.
Hello, Markle.
Hello.
Can you hear me?
Yes.
I have a case of a little boy, 5 years old. He didn't speak. and the doctor say, doctor recommend him for speech therapy. They told mother that the lack of speech, he didn't say anything. Can you tell me the reason behind it?
I think I got,
Because after a year, he stopped saying anything.
I'm so sorry, Nishta. I heard some of your question, but I couldn't hear clearly all of it.
Yeah.
Would it
Can
be,
I write in chat
yes,
box?
you can write it in the chat box. That's what I was going to
Okay,
recommend.
okay.
Thank you.
Thank you.
While Nisha is writing her chat box in, was there any other questions that we have for Kalli while we're waiting on her?
As that question comes in. Oh, Crystal popped a question in too. How much does the testing cost families typically? I feel like that's a question I should know, and I do not know. I'm gonna guess it's a few $100s here at USU, but we do take insurance. And I've seen families from like Tooele and Blanding up here in northern Utah because I'm the only one who takes their insurance. So I do think some of the clinics might be limited in who they're contracted with insurances where they might offer it self-pay. But I think I would guess around a few $100s depending on where you go and if insurance does not cover it.
Okay. So just moving on from kind of what Kalli talked about, I think that this came up because I don't know if it was a few months ago or a year ago during one of our case presentations, we were having a lot of, like Natalie had said, a lot of recommendations for or schools or audiologists in the community just saying that kids had auditory processing disorders. And so we wanted to look at that a little more closely. And I think part of the thing that we've recognized is that it can't be diagnosed by just one provider or just one profession. So listening difficulties encompass the auditory processing piece, which audiology tests for. It also looks at cognition, attention, working memory, and then ability to process language. So we look at a lot of different measures. We look at the auditory processing test that Kalli talked about. We look at standardized language measures that look at receptive and expressive vocabulary, grammar, the ability to follow directions, recall sentences, do inferencing. We look at memory and attention in terms of short-term memory and working memory, selective auditory attention. Can they switch attention between different tasks? And then long-term memory retrieval. How accurate is memory being retrieved from long-term memory? Part of our assessments for speech and language are either conducted in, well, we've done it both ways. Sometimes we go first and then we send them over to Kalli and say, we think that we should do audiological testing, and sometimes she'll send them to us, but we've tried to work really closely and look at really the sensitive areas within language. So phonological processing, lexical knowledge, narrative language assessment, and metalinguistic assessments. We've also realized that sometimes there's not just one test or one score that would meet the qualifying criteria. So you could have a kiddo who does really well in one area and completely bombs in another area. So using a combination of performance across multiple areas, looking at cognition, language, audition, academics, to support any kind of a justification for services like a 504 plan or an IEP, and recognizing that auditory processing is not on its own something that schools are going to recognize as for an IEP or as a disability area. So we kind of have to shift from a singular diagnosis to looking more at all of the child's weaknesses and how they are having a cumulative effect on their listening and their communication. Some of the sensitive areas in language testing that we look at are phonological processing, vocabulary, retrieval from long-term memory, short-term memory, sentence recall, metalinguistics, narratives, reading, decoding, and comprehension. And I think something that we've come to realize is that many children exhibit listening difficulties. In previous sessions, we've talked about language development and trauma, fetal alcohol syndrome and language development, substance abuse and language development. And all of these often have a listening component due to the number of neural and language connections that are needed to be an effective listener. So it's not always just one diagnosis. And it can be really confusing for families to navigate, and it often takes a lot of visits with a lot of different providers to figure out exactly what's happening. In terms of phonological processing, we look at discrimination, pattern recognition, memory, sequencing, and decoding. We also look at vocabulary knowledge, which is usually a strength for kids with listening difficulties because they figure out the vocabulary from the context. So while they may not be able to hear or differentiate different sounds within words, they can often pick up on words based on context. And so they'll have a high vocabulary, which will throw people off and think, oh, well, maybe it's not auditory processing because they really have pretty high vocabulary knowledge. But the problem with just looking at vocabulary is that they don't really capture the complex nature of all of the lexical processing. So we need to look at word association, semantic networks, speech processing and recall, accuracy, and word retrieval. So there's a lot of different components on the language side that we have to look at. For vocabulary knowledge, it really predicts their ability to listen in degraded listening conditions. So a noisy classroom, if the teacher's got the kids in the gym, if you've got your kids at the zoo and it's noisy, having that vocabulary knowledge is a good predictor of whether or not that child's going to be able to listen in those conditions, and being able to rely on memory and processing abilities to resolve any listening challenges. The quality of the lexical representation and retrieval are important factors. And we have to look at all of those things as we're trying to test kids to determine if it could possibly be an auditory processing disorder. So what we know for sure is that many children with listening difficulties will have a normal audiogram. But there's a comorbidity of auditory processing deficits and working memory deficits with other developmental disorders. That's usually the rule, it's not the exception. So other diagnosis, autism spectrum, ADHD, Williams syndrome, trauma-related language delays, they all have overlapping symptomology and higher incidence of listening difficulties. So the diagnosis often gets thrown around a lot and sometimes comes out to be just kind of a catch-all diagnosis. When I worked in the schools, and it's been 10 years ago, but what we did was we gave the parents and the teacher an Fisher's auditory problem checklist, and they'd fill it out. And if the kid was having more problems than they weren't, we said, oh, they must have an auditory processing disorder, which is not the best way to diagnose that in order to help the kids receive the treatment that they need. So it's really important to rule out other diagnoses through audiological testing, neuropsychological testing, and speech language evaluations, so that we know exactly what we're dealing with. If we look at language, listening, communication, and trauma, which this scope focuses on substance abuse and, you know, the impacts that that has on children as they're developing and the trauma that causes. So we're looking at kiddos with more language concerns than their peers without trauma histories, more listening difficulties, a more limited vocabulary, an inability to follow directions, difficulty with language comprehension and production, and difficulties with pragmatics. They also have a higher occurrence of ADHD, but are often misdiagnosed as being on the autism spectrum or being oppositional defiant, having sensory integration dysfunction or a learning disability. So what can we do? I think that the first thing we can do is get a really accurate diagnosis of what's going on with the kid. And then in terms of therapies, we enrich their overall language knowledge and processing abilities. So phonological awareness and vocabulary. We try and enhance language knowledge and processing to improve listening in complex auditory environments. By reducing the cognitive load. So really trying to simplify things for these kiddos. You know, let's do a one-step direction, not a 2 or 3-step direction. Let's use pictures to help communicate just as often as we use our words. Let's do things that will optimize their attention and then integrate auditory environments with functional experiences like music and play and social interactions. So the SLP treatment recommendations that we typically give are phonological intervention, interventions to strengthen lexical knowledge networks and processing, training listening to spoken language in a functional way, and promoting early auditory language enrichment for all kids at risk. Now we're back to the questions, and it looks like we have a few. So I'm going to stop sharing so we can see each other in chat.
Thank you, Jamie. It does look like we have the question from Nisha that came in. Did you guys want to go ahead and let me read it, and then you guys can address that if you'd like. A male child who is 5 years old stopped speaking after an episode of high fever when he was 1 year old. He doesn't speak a word, and his reactions to anything is very slow post-fever. His mother started taking him for speech therapy. Doctors also diagnosed speech delay, and after 2 years, the boy started calling mom, dad, and many more words, which is easy for him, but he still didn't talk like other kids of his age. Is there any advice that we can give the mother to help her son to speak? That's a great question.
Yeah. I think one thing that's really tricky is that high fevers can cause a bit of chaos in the auditory system and maybe also in the speech and language system. Jamie, maybe you know more about that, but I would consider checking his hearing levels. So I've had quite a few patients who have fever disorders who end up having hearing loss or intermittent.
No, it's a normal fever.
His hearing is all normal?
Yeah, its fever was normal.
Okay.
Yeah.
Yeah, so then I think it might be helpful to know if maybe there is a delay of the sound getting in, like the auditory processing. It could be helpful to look at auditory processing if you have access to audiology and they have APD testing. That might be helpful to know. But what else would you say, Jamie? I mean, I think everything you just talked about, the speech and language interventions, could be really helpful too.
You recommend him for EPG test, right?
I'm sorry, I didn't quite hear you.
You told me for EPG test.
The connection's really fuzzy, so we can't understand.
Sorry?
Nisha, if you would like to go ahead, we're just having a little bit of a hard time with the connection. If you would like to go ahead and type into the chat,
Okay.
we'll be able to continue answering questions even through the chat. or Kalli, would you be okay giving out your email to Nishta and you guys could connect?
I'm starting to just type out a response too, because that's where the clarification is tricky. Yep, I would say, yep, if you have access to providers who can do the ABR test, that might be helpful to know the timing of how sounds are getting in. If his speech is still delayed, that and his hearing is normal, he might still have a listening deficit. But then you could also talk to his speech language providers because they started speech therapy. That's where you can incorporate a lot of what Jamie talked about.
Yeah, and I would be happy to, send any information or talk to speech providers if, I will also put my email in. I think the thing about having a speech delay is that it takes a long time. It's not a quick fix. So, the fact that he's starting to speak and starting to use words is a positive indicator, but I think that there may be some more language enriching activities or augmentative alternative types of communication that could help him to start communicating that we could definitely talk about.
Thank you. That's great. Great question. We have maybe 1 more minute for questions if we had any others for Jamie or Kalli before we move on to our case presentation. All right, it looks like there wasn't any more questions. I'm sure we could also reach out to you too if needed. We just wanted to thank both of you for that wonderful presentation on different testing methods and ways to help these kiddos. That was fascinating. So thank you both for your time and your knowledge and for being willing to share that with us. All right, we are going to go ahead and move on to our case presentation. We have Olivia Gruwell who has one for us today. I'm going to turn it over to you.
Okay, can everybody see the presentation? Okay, perfect. Okay, let me pull my info over. So today, some of you who might have been at the Utah County Partners for Family and Children meeting yesterday, this will be a review, but just to kind of review and kind of go deeper down into what this case is. So just to give a little bit of perspective, I work with the Infant Toddler Court Program in Utah County. We use the Safe Babies approach. And so I work as a neutral third party, kind of a liaison between families, court officials, the state, and community providers who are providing support to a family that has a child between the ages 0 to 3 involved in a child welfare case. And so this is a case that we've had recently that I wanted to bring to the table. So some background about this case is that so child welfare case was opened for the parent substance use and neglect. First, it was the first child welfare case for both parents. There's no known history of either parent being involved in child welfare previously as children or adults. And there are prior incarceration experiences for drug and other unknown charges. So with the family, it is a white family with extensive extended family in Utah. The extended family is a mix of religious and non-religious, with the parents not being actively religious or connected to any church organization. There are 2 parents, a mother and a father, with 1 infant male child and extended family involvement, including grandparents, aunts, and uncles within the team. The child was placed with the aunt and uncle and will be adopted by them. There are no known disabilities for either parent or the child. The parent lives in Utah County and extended family lives just south of Utah County. So that's just like a little bit of background. The primary area of concern. So for dad, we want to continue supporting him in his sobriety and support needed following mom's passing an overdose this summer. So for the child, we want to provide extra support in the adoptive home for the family and continuing that connection between dad and child post-adoption. Aunt and uncle have said that they would like to continue fostering that relationship between the child and his biological father, and they've been very actively involved in supporting him. Dad has reported being sober and doing well, but we aren't sure as we haven't received reports from his treatment center or any of the UAs, drug tests that he has completed. So kind of primarily our goals with this family is to help the child grow up with as many safe and loving caregivers and relationships that he can have. So we want to provide support to this family in fostering that all of them can continue to be loving and supportive adults in this child's life. For Dad, we want to support him with his continued sobriety so that he can continue to build a relationship with his son. And we would also like to see whatever resources we could provide to the adoptive family so that they have support as the child grows. Kind of just envisioning that as the child gets older and their needs change, like the support they need is going to change. And the adoptive family is just south of Utah County. I'm not sure exactly where, but it's within like an hour-ish drive. And then the barriers, another goal that I personally have, not specific to this family, but I would also like to discuss resources that we could have implemented to help better support mom. So when the kind of story behind when, well, maybe I have this on the next slide, but if I do, I'll just skip it. But the story behind when she passed was that she was in a residential treatment program. She got out. We tried to contact her the day that she was completed that program and a few times that week. And we next had heard a report that she had passed from an overdose. So that's one of the things that I'm keeping in mind as we go into the future to help other similar families with similar situations. Some of the barriers is that we don't know of any resources really down in south of Utah County. Dad is unemployed. He lives with friends and families, kind of couch hopping a little bit and doesn't have any means of transportation. He's been employed and unemployed back and forth, but it's been very difficult as where he lives, doesn't have any kind of public transportation. He needs continued support from the community following this adoption and case closure. So the way our program works is that it's supposed to say is set up, but that families are in contact with their team about every 2 weeks, switching between family team meetings and court hearings compared to a traditional child welfare case where they meet about once every 3 months for each. So it's a lot of more support. The entire team consistently contacted this family about once every 2 weeks, and the caseworker was in contact a couple times a week. We provided Dad with a bus pass, but he lives in an area where there's just not buses. And so he's had a hard time, as I mentioned. We did try to provide Dad with options for treatment and testing that would be easier and closer to him, but it was difficult for him to follow through with them and for us to communicate with those. Dad's preferred provider would not do randomized UAs, which unfortunately means it doesn't fulfill the court order's request because the court does require that those be random. We attend, like I talked about mom, the family team meetings were really beneficial in supporting Dad and extended family. Dad was struggling with suicidal thoughts and intentions over the summer, and the family team meetings allowed that the team and extended family to create a support plan for him. And his extended family was integral in supporting him through the last 3 months leading to the termination of reunification services. In the months since then, Dad's really excited about this case closing and being able to see his son more often, since his aunt and uncle will be able to determine the safety for the child and how often he gets to see him rather than the court system. So that's kind of it's heading in a positive way, as positive as any adoption case like this could go. So yeah, the community discussion is what are 2 or 3 things. I don't know. Do you want, this is me. So we would like social support networks that could have helped mom, supports for the family as the case closes. And then just any ideas on transportation services available or anything relevant to helping families struggling with similar challenges. Because I feel like the reason I selected this case in particular is I feel like it highlights a lot of pretty common challenges that a lot of families face within the child welfare system.
Thank you, Olivia. That case really tugs on your heart, doesn't it?
Yes. Yeah, we have spent a lot of time thinking about it. So.
Okay, well, let's see if we can get some good suggestions and recommendations for you.